Inflammation concept exemplar, acute pancreatitis. Pathophysiology review. Acute pancreatitis is a serious and at times life-threatening inflammation of the pancreas. This inflammatory process is caused by a premature activation of excessive pancreatic enzymes that destroy ductal tissue and pancreatic cells, resulting in autodigestion and fibrosis of the pancreas. The pathologic changes occur in different degrees. The severity of pancreatitis depends on the extent of inflammation and tissue damage. Pancreatitis can range from mild involvement evidenced by edema and inflammation to necrotizing hemorrhagic pancreatitis. NHP is diffuse bleeding pancreatic tissue with fibrosis and tissue death. The pancreas is unusual in that it functions as both an exocrine gland and an endocrine gland. The primary endocrine disorder is diabetes mellitus and is discussed in Chapter 59. The exocrine function of the pancreas is responsible for secreting enzymes that assist in the breakdown of starches, proteins, and fats. These enzymes are normally secreted in the inactive form and become activated once they enter the small intestine. Early activation results in the inflammatory process of pancreatitis. Direct toxic injury to the pancreatic cells and the production and release of pancreatic enzymes result from the obstructive damage. After pancreatic duct obstruction, increased pressure may contribute to ductal rupture, allowing spillage of trypsin and other enzymes into the pancreatic parenchymal tissue. Autodigestion of the pancreas occurs as a result. In acute pancreatitis, four major pathophysiologic processes occur: lipolysis, proteolysis, necrosis of blood vessels, and inflammation. The hallmark of pancreatic necrosis is enzymatic fat necrosis of the endocrine and exocrine cells of the pancreas caused by the enzyme lipase, fatty acids are released during this lipolytic process and combine with ionized calcium to form a soap-like product. The initial rapid lowering of serum calcium levels is not readily compensated for by the parathyroid gland. Because the body needs ionized calcium and cannot use bound calcium, hypocalcemia occurs. Proteolysis involves the splitting of proteins by hydrolysis of the peptide bonds, resulting in the formation of smaller polypeptides. Proteolytic activity may lead to thrombosis and gangrene of the pancreas. Pancreatic destruction may be localized and confined to one area or may involve the entire organ. Elastase is activated by trypsin and causes elastic fibers of the blood vessels and ducts to dissolve. The necrosis of blood vessels results in bleeding, ranging from minor bleeding to massive hemorrhage of pancreatic tissue. Another pancreatic enzyme, kallikrein, causes the release of vasoactive peptides, bradykinin, and a plasmakinin known as kallidin. These substances contribute to vasodilation and increased vascular permeability, further compounding the hemorrhagic process. This massive destruction of blood vessels by necrosis may lead to generalized hemorrhage, with blood escaping into the retroperitoneal tissues. Many deaths in patients with acute pancreatitis result from irreversible hypovolemic shock due to hemorrhage. The inflammatory stage occurs when leukocytes cluster around the hemorrhagic and necrotic areas of the pancreas. A secondary bacterial invasion may lead to suppuration of the pancreatic tissue called a pancreatic abscess. Pancreatic abscesses must be drained promptly to prevent sepsis. Mild infected lesions may be absorbed. When infected lesions are severe, calcification and fibrosis occur. If the infected fluid becomes walled off by fibrous tissue, a pancreatic pseudocyst forms. Pseudocysts often rupture spontaneously but may require surgical removal. Figure 542. The process of autodigestion in acute pancreatitis. Complications of acute pancreatitis. Acute pancreatitis may result in severe, life-threatening complications. Jaundice occurs from swelling of the head of the pancreas, which slows bile flow through the common bile duct. The bile duct may also be compressed by calculi or a pancreatic pseudocyst. The resulting total bile flow obstruction causes severe jaundice. Intermittent hyperglycemia occurs from the release of glucagon, as well as the decreased release of insulin due to damage to the pancreatic islet cells. Total destruction of the pancreas may occur, leading to type 1 diabetes mellitus. Left lung pleural effusions frequently develop in the patient with acute pancreatitis. Atelectasis and pneumonia may occur also, especially in older patients. Multisystem organ failure is caused by necrotizing hemorrhagic pancreatitis. The patient is at risk for acute respiratory distress syndrome. This severe form of pulmonary edema is caused by disruption of the alveolar capillary membrane and is a serious complication of acute pancreatitis. In acute pancreatitis, pulmonary failure accounts for more than half of all deaths that occur in the first week of the disease. Coagulation defects are another major potential complication and may result in death. Complex physiologic changes in the pancreas cause the release of necrotic tissue and enzymes into the bloodstream, resulting in altered coagulation. Disseminated intravascular coagulation involves hypercoagulation of the blood, with consumption of clotting factors and the development of microthrombi. Shock in acute pancreatitis results from peripheral vasodilation from the released vasoactive substances and the retroperitoneal loss of protein-rich fluid from proteolytic digestion. Hypovolemia may result in decreased renal perfusion and acute renal failure. Paralytic ileus results from peritoneal irritation and seepage of pancreatic enzymes into the abdominal cavity. Etiology and genetic risk. In many cases, the cause of pancreatitis is not known, but many factors can injure the pancreas. The most common cause is biliary tract disease, with gallstones accounting for almost half of the cases of obstructive pancreatitis. Acute pancreatitis may occur as a result of trauma from surgical manipulation after biliary tract, pancreatic, gastric, and duodenal procedures, such as cholecystectomy, the Whipple procedure, and partial gastrectomy. The trauma may also occur as a complication of the diagnostic procedure endoscopic retrograde cholangiopancreatography, although this rarely occurs. Additional factors that can cause acute pancreatitis are listed in Table 544. Table 543. Pancreatic infection, hemorrhage, acute kidney failure, paralytic ileus, hypovolemic shock, pleural effusion, acute respiratory distress syndrome, atelectasis, pneumonia, multi-organ system failure, disseminated intravascular coagulation, type 2 diabetes mellitus, potential complications of acute pancreatitis, incidence and prevalence. Pancreatic attacks are especially common during holidays and vacations when alcohol consumption may be high, especially in men. Women are affected most often after having cholelithiasis and biliary tract problems. They are also most at risk for pancreatitis within several months after childbirth. Death occurs in a small percentage of patients with acute pancreatitis, but with early diagnosis and treatment, mortality can be reduced. It occurs at a higher rate in older adults and in patients with postoperative pancreatitis. The prognosis for recovery is usually good for pancreatitis associated with biliary tract disease and poor if pancreatitis accompanies alcoholism. Interprofessional collaborative care. Care for the patient with acute pancreatitis usually takes place in the hospital setting for pain control and possible surgical intervention. Assessment, recognize cues. History. Most often the patient reports severe and constant abdominal pain. Conduct the interview after pain is controlled. Ask whether the abdominal pain occurs when drinking alcohol or eating a high-fat meal. Obtain information about alcohol use, including the amount of alcohol consumed during what period of time. Question the patient about a family or personal history of alcoholism, pancreatitis, trauma, or biliary tract disease. Ask whether any abdominal surgical interventions such as cholecystectomy or diagnostic procedures such as ERCP have been performed recently. Table 544. Trauma, external, pancreatic obstruction, tumors, cysts, or abscesses, abnormal organ structure. Metabolic problems, hyperlipidemia, hyperparathyroidism, or hypercalcemia. Renal involvement, failure or transplantation. Familial, inherited pancreatitis. Penetrating gastric or duodenal ulcers, resulting in peritonitis. Viral infections such as Coxsackie virus B and human immune deficiency virus infection. Alcoholism. Toxicities of drugs, including opiates, sulfonamides, thiazides, steroids, and oral contraceptives. Cigarette smoking and tobacco use. Cystic fibrosis. Gallstones. Factors that can cause acute pancreatitis. Ask about other medical problems known to cause pancreatitis. Inquire about recent viral infections. Ask the patient or family member to list all prescription and over-the-counter drugs taken recently, including nutritional and herbal supplements. Physical assessments/signs and symptoms. The diagnosis of acute pancreatitis is made based on the clinical presentation combined with the results of diagnostic studies, both laboratory and imaging assessments. Symptoms of acute pancreatitis vary widely and depend on the severity of the inflammation. Typically, a patient is diagnosed after presenting with severe abdominal pain in the mid-epigastric area or left upper quadrant. Assess the intensity and quality of pain. The patient often states that the pain had a sudden onset and radiates to the back, left flank, or left shoulder. The pain is described as intense, boring, and continuous, and is worsened by lying in the supine position. Often the patient finds relief by assuming the fetal position or by sitting upright and bending forward. He or she may report weight loss resulting from nausea and vomiting. Obtain the patient's weight. When performing an abdominal assessment, inspect for 1. Generalized jaundice. 2. Gray-blue discoloration of the abdomen and periumbilical area. 3. Gray-blue discoloration of the flanks, caused by pancreatic enzyme leakage to cutaneous tissue from the peritoneal cavity. Listen for bowel sounds. Absent or decreased bowel sounds usually indicate paralytic ileus. On light palpation, note abdominal tenderness, rigidity, and guarding as a result of peritonitis. Pancreatic ascites creates a dull sound on percussion. Monitor and record vital signs frequently to assess for elevated temperature, tachycardia, and decreased blood pressure, or assign and closely supervise this activity. Auscultate the lung fields for adventitious sounds or diminished breath sounds and observe for dyspnea or orthopnea. Nursing safety priority. Critical rescue. For the patient with acute pancreatitis, monitor for significant changes in vital signs that may indicate the life-threatening complication of shock. Hypotension and tachycardia may result from pancreatic hemorrhage, excessive fluid volume shifting, or the toxic effects of abdominal sepsis from enzyme damage. Observe for changes in behavior and level of consciousness that may be related to alcohol withdrawal, hypoxia, or impending sepsis with shock. Psychosocial assessment. If excessive alcohol is a causative factor, tactfully explore the patient's alcohol intake history after the patient has adequate pain control. Provide patient privacy and establish a trusting relationship. Discuss the intake of alcohol and the reasons for overindulging. Using the CAGE questionnaire to assist with determining alcohol use may be beneficial. Ask the patient when increased drinking episodes occur and, in particular, whether binges occur during holidays, vacations, or weekends or revolve around particular activities, such as television viewing. Question him or her about any recent traumatic or stressful event that may have contributed to increased alcohol consumption, such as the death of a family member or a job loss. Table 545. Abnormal finding cause. Increased amylase pancreatic cell injury. Elevated lipase pancreatic cell injury. Elevated trypsin pancreatic cell injury. Elevated elastase pancreatic cell injury. Other diagnostic tests. Elevated glucose pancreatic cell injury resulting in impaired carbohydrate metabolism, decreased insulin release. Decreased calcium and magnesium fatty acids combined with calcium, seen in fat necrosis. Elevated bilirubin hepatobiliary obstructive process. Elevated alanine aminotransferase hepatobiliary involvement/obstruction. Elevated aspartate aminotransferase hepatobiliary involvement. Elevated leukocyte count and presence of C-reactive protein inflammatory response. Causes of serum laboratory abnormalities in acute pancreatitis. Laboratory assessment. Diagnostic laboratory abnormalities are typical in patients with acute pancreatitis. A variety of pancreatic and non-pancreatic disorders can cause increased serum amylase levels. In patients with pancreatitis, amylase levels usually increase within 12 to 24 hours and remain elevated for 2 to 3 days. Persistent elevations may be an indicator of duct obstruction or pancreatic duct leak. Lipase also helps determine the presence of acute pancreatitis. Serum levels may rise later than amylase and remain elevated for up to 2 weeks. Because these levels stay elevated for such a long time, the primary healthcare provider may find this test useful in diagnosing patients who are not examined until several days after the initial onset of symptoms. An increase in lipase and amylase in the urine is also expected. If pancreatitis is accompanied by biliary dysfunction, serum bilirubin and alkaline phosphatase levels are usually elevated. A sensitive indicator of biliary obstruction in acute pancreatitis is serum alanine aminotransferase. A threefold or greater rise in concentration indicates that the diagnosis of acute biliary pancreatitis is valid. Elevated white blood cell count and differential, erythrocyte sedimentation rate, and serum glucose levels are also common in acute pancreatitis. The levels often correlate with disease severity. Decreased serum calcium and magnesium levels are seen with fat necrosis. Calcium levels may fall and remain decreased for 7 to 10 days. Those that consistently remain below 8 mg per deciliter are associated with a poor prognosis. Other tests include the basic metabolic panel, complete blood count, triglycerides, serum total protein, and albumin. The blood urea nitrogen, serum glucose, and triglycerides are usually elevated. Hemoconcentration is common as a result of third-space fluid loss. Leukocytosis and thrombocytopenia are common. Albumin levels are decreased because cytokines released as part of the inflammatory response allow it to move from the bloodstream into the extravascular space. The presence of C-reactive protein suggests possible pancreatic inflammation and necrosis. Imaging assessment. Abdominal ultrasound is the most sensitive test to diagnose causes of pancreatitis, such as gallstones, and can be performed at the bedside. However, it is not helpful in viewing the pancreas because of overlying bowel gas. Therefore, contrast-enhanced CT provides a more reliable image and diagnosis of acute pancreatitis. This non-invasive technique may also be used to rule out pancreatic pseudocystic ductal calculi. An abdominal X-ray may also reveal gallstones. A chest X-ray may show elevation of the left side of the diaphragm or pleural effusion. Pancreatic stones are best diagnosed through ERCP analysis, analyze cues, and prioritize hypotheses. The priority collaborative problems for patients with acute pancreatitis include 1. Severe acute pain due to pancreatic inflammation and enzyme leakage. 2. Weight loss due to inability to ingest food and absorb nutrients. NCLEX Examination Challenge 542. Physiologic integrity. A client was admitted to the hospital yesterday with a diagnosis of acute pancreatitis. What assessment findings will the nurse expect for this client? Select all that apply. A. Severe boring abdominal pain. B. Jaundice. C. Nausea and/or vomiting. D. Decreased serum amylase level. E. Leukocytosis. F. Dyspnea. Planning and implementation. Generate solutions and take action. Managing acute pain. Planning. Expected outcomes. The patient with acute pancreatitis is expected to state that he or she has a decrease in or absence of abdominal pain as evidenced by self-report of a level of 2 or 3 on a 0-10 pain intensity scale. Interventions. The priorities for care for the patient with acute pancreatitis are to provide supportive care by relieving symptoms, to decrease inflammation, and to anticipate or treat complications. As for any patient, continually assess for and support the ABCs. In collaboration with the respiratory therapist, if available, provide oxygen and other respiratory support as needed. The collaborative plan of care depends on the severity of the illness. Severe continuous boring abdominal pain is the most common symptom of pancreatitis. The main focus of nursing care is aimed at controlling pain interventions that decrease GI tract activity, thus decreasing pancreatic stimulation. Pain assessment to measure the effectiveness of these interventions is an essential part of nursing care. Non-surgical management. Mild pancreatitis requires hydration with 4 fluids, pain control, and drug therapy. The interprofessional healthcare team initially attempts to relieve pain with non-surgical interventions, which include fasting and rest, drug therapy, and comfort measures. If the patient has a life-threatening complication or requires frequent assessment, he or she is admitted to a critical care unit for invasive hemodynamic monitoring. To rest the pancreas and reduce pancreatic enzyme secretion, withhold food and fluids during the acute period. The primary healthcare provider prescribes 4 isotonic fluid administration to maintain hydration. For a replacement of calcium and magnesium may also be needed. Measure and document intake and output. Some patients have an indwelling urinary catheter to obtain accurate measurements. Nasogastric drainage and suction are reserved for more severely ill patients who have continuous vomiting or biliary obstruction. Gastric decompression using a nasogastric tube prevents gastric juices from flowing into the duodenum. Nursing safety priority. Action alert. Because paralytic ileus is a common complication of acute pancreatitis, prolonged nasogastric intubation may be necessary. Assess frequently for the return of peristalsis by asking the patient if he or she has passed flatus or had a stool. The return of bowel sounds is not reliable as an indicator of peristalsis return. Passage of flatus or a bowel movement is the most reliable indicator. See the discussion of intestinal obstruction in Chapter 51. Pain management for acute pancreatitis typically begins with the administration of opioids by patient-controlled analgesia. Drugs such as morphine or hydromorphone are typically given. Other options that have been used successfully to manage acute pain include 4 or transdermal fentanyl and epidural analgesia. In mild pancreatitis, the pain usually subsides in 2 to 3 days. However, with severe acute pancreatitis, the abdominal pain and tenderness may persist for up to 2 weeks. Drug dosages and intervals are individualized according to the severity of the disease and the symptoms. Histamine receptor antagonists and proton pump inhibitors help decrease gastric acid secretion. Antibiotics may be prescribed, but they are indicated primarily for patients with acute necrotizing pancreatitis or pancreatic abscess. Helping the patient assume a side-lying position may help decrease the abdominal pain of pancreatitis. Sitting with the knees flexed toward the chest is also helpful. If the patient is NPO or has an NGT, remind assistive personnel to implement frequent oral and nares hygiene measures to keep mucous membranes moist and free of inflammation or crusting. Because of the drying effect of drugs and the absence of oral fluids, the mouth and oral cavity may be extremely dry, resulting in considerable discomfort and possibly parotitis. Nursing safety priority. Action alert. For the patient with acute pancreatitis, monitor his or her respiratory status every 4 to 8 hours or more often as needed and provide oxygen to promote comfort in breathing. Respiratory complications such as pleural effusions increase patient discomfort. Fluid overload can be detected by assessing for weight gain, listening for crackles, and observing for dyspnea. Carefully monitor for signs of respiratory failure. Observe for signs and symptoms of hypocalcemia, such as muscle twitching, numbness, and irritability. Chapter 13 discusses assessment and care of patients with hypocalcemia in more detail. Lowering the patient's anxiety level may also reduce pain. Explain all procedures and other aspects of patient care thoroughly. Provide reassurance, offer diversional activities such as music and reading material, and encourage visitors to direct attention away from the pain. If pancreatitis was caused by gallstones, an ERCP with a sphincterotomy may be performed on an urgent or emergent basis. If this procedure is not successful, surgery is required. ERCP is described in detail in Chapter 48. Surgical management. Surgical intervention for acute pancreatitis is usually not indicated. However, if an ERCP is not successful in removing gallstones, a laparoscopic cholecystectomy may be performed as described in the surgical management discussion in the section Inflammation Concept Exemplar, cholecystitis. Complications of pancreatitis, such as pancreatic pseudocyst and abscess, may also require surgical intervention. Laparoscopy may be done to drain an abscess or pseudocyst. For patients who are at high surgical risk, pseudocysts or abscesses can be treated by percutaneous drainage under CT guidance. Promoting nutrition. Planning expected outcomes. The patient with acute pancreatitis is expected to have adequate nutrition to meet his or her metabolic needs. Interventions. The patient is maintained on NPO status in the early stages of pancreatitis. Antiemetics for nausea and vomiting are prescribed as needed. Patients who have severe pancreatitis and are unable to eat for 24 to 48 hours after illness onset may begin jejunal tube feeding unless paralytic ileus is present. Early nutrition intervention enhances immune system functioning and may prevent complications and worsening inflammation. Enteral feeding is preferred over total parenteral nutrition because it causes fewer episodes of glucose elevation and other complications associated with TPN. Be sure that the patient is weighed every day. Collaborate with the primary healthcare provider, registered dietitian nutritionist, and pharmacist to plan and implement the most appropriate nutrition intervention. Chapter 55 describes collaborative care of patients receiving enteral feeding and TPN. When food is tolerated during the healing phase, the primary healthcare provider prescribes small, frequent, moderate to high carbohydrate, high protein, low fat meals. Food should be bland with little spice. GI stimulants such as caffeine-containing food, as well as alcohol, should be avoided. Monitor the patient beginning to resume oral food intake for nausea, vomiting, and diarrhea. If any of these symptoms occur, notify the primary healthcare provider immediately. To boost caloric intake, commercial liquid nutritional preparations supplement the diet. The healthcare provider may also prescribe fat-soluble and other vitamin and mineral replacement supplements. Glutamine, omega-3 fatty acids, fiber, antioxidants, and or nucleotides may be added to the patient's nutrition plan. Care coordination and transition management. Home care management. Home care preparation is individualized for each patient's circumstances. Some patients may be severely weakened from their acute illness and need to confine activity to one floor, limiting stair climbing and other strenuous activities until they regain their strength. Collaborate with the case manager to plan the best place for the patient to recover and resources that may be needed. Self-management education. Education needs to be started early in the hospitalization period, as soon as the acute episodes of pain have subsided. Assess the patient's and family's knowledge of the disease. The desired outcomes for discharge planning and education are to avoid further episodes of pancreatitis and prevent progression to a chronic disease. If the patient uses alcohol, instruct him or her to abstain from drinking to prevent further pain attacks and extension of inflammation and pancreatic insufficiency. Tell the patient that if alcohol is consumed, acute pain will return, and further autodigestion of the pancreas may lead to chronic pancreatitis. Teach the patient to notify the primary healthcare provider after discharge to home if acute abdominal pain or biliary tract disease occurs. These signs and symptoms are possible indicators of complications or disease progression. Healthcare resources. Patients with acute pancreatitis may require several visits by a home care nurse if the hospital course was complicated. In these cases, home care may be needed for wound care and assistance with ADLs. The patient requires medical follow-up with the primary care provider to monitor the disease process. For those with alcoholism, provide information about groups such as Alcoholics Anonymous. Family members may attend support groups such as Al-Anon and Alateen. Evaluation. Evaluate outcomes. Evaluate the care of the patient with acute pancreatitis based on the identified priority patient problems. The expected outcomes include that the patient will 1. Have control of abdominal pain as indicated by self-report and pain scale measurement. 2. Have adequate nutrition available to meet metabolic needs. Chronic pancreatitis. Pathophysiology review. Chronic pancreatitis is a progressive, destructive disease of the pancreas that has remissions and exacerbations. Inflammation and fibrosis of the tissue contribute to pancreatic insufficiency and diminished function of the organ. Chronic pancreatitis can be classified into several categories. Alcoholism is the primary risk factor for chronic calcifying pancreatitis, the most common type. In the early stages of the disease, pancreatic secretions precipitate as insoluble proteins that plug the pancreatic ducts and flow of pancreatic juices. As the protein plugs become more widespread, the cellular lining of the ducts changes and ulcerates. This inflammatory process causes fibrosis of the pancreatic tissue. Intraductal calcification and marked pancreatic tissue destruction develop in the late stages. The organ becomes hard and firm as a result of cell atrophy and pancreatic insufficiency. CCP is found predominantly in men, but the incidence in women is increasing. In women, chronic pancreatitis occurs more commonly among those with biliary tract disease. Chronic obstructive pancreatitis develops from inflammation, spasm, and obstruction of the sphincter of Oddi, often from cholelithiasis. Inflammatory and sclerotic lesions occur in the head of the pancreas and around the ducts, causing an obstruction and backflow of pancreatic secretions. Autoimmune pancreatitis is a chronic inflammatory process in which immunoglobulins invade the pancreas. Other organs may also be infiltrated, including the lungs and liver. There is evidence to show that autoimmune pancreatitis puts the patient at risk for pancreatic cancer. Idiopathic and hereditary chronic pancreatitis may be associated with SPIN1 and CFTR gene mutations and with mutations in the BRCA2 gene. People with hereditary pancreatitis have been shown to have a 53-fold increased risk of pancreatic cancer. The protein encoded by the SPIN1 gene is a trypsin inhibitor. The CFTR gene is associated with cystic fibrosis. Research on these gene mutations can help in developing targeted drug therapy for treatment of these diseases. Pancreatic insufficiency in any type of chronic pancreatitis causes loss of exocrine function. Most patients with chronic pancreatitis have decreased pancreatic secretions and bicarbonate. Pancreatic enzyme secretion must be greatly reduced to produce steatorrhea resulting from severe malabsorption of fats. These characteristic stools are pale, bulky, and frothy and have an offensive odor. The action of colonic bacteria on unabsorbed lipids and proteins is responsible for the extremely foul odor. On inspection of the stools, the fat content is visible. Fat malabsorption also contributes to weight loss and muscle wasting and leads to general debilitation. Protein malabsorption results in a starvation edema of the feet, legs, and hands caused by decreased levels of circulating albumin. The loss of pancreatic endocrine function is responsible for the development of diabetes mellitus in patients with chronic pancreatic insufficiency. The patient with chronic pancreatitis may have pulmonary complications, such as pleuritic pain, pleural effusions, and pulmonary infiltrates. Pancreatic ascites may decrease diaphragmatic excursion and lung expansion, resulting in impaired ventilation. In the ill patient with chronic pancreatitis, acute respiratory distress syndrome may develop. Interprofessional collaborative care. Care for the patient with chronic pancreatitis takes place in the home or community setting but moves to the hospital setting for pain control and possible surgical intervention. Assessment. Recognize cues. Many symptoms of chronic pancreatitis differ from those of an acute inflammation. Abdominal pain is the major symptom for most types of pancreatitis. For those with chronic pancreatitis, pain is typically described as a continuous burning or gnawing dullness with periods of acute exacerbation. The pain is very intense and relentless. The frequency of acute exacerbations may increase as the pancreatic fibrosis develops. Key features of chronic pancreatitis are listed in the Key Features, Chronic Pancreatitis box. Perform an abdominal assessment. Abdominal tenderness is less intense in patients with chronic pancreatitis than in those with acute pancreatitis. Massive pancreatic ascites may be present, producing dullness on abdominal percussion. Because respiratory complications can occur, auscultate the lung fields for adventitious sounds or decreased aeration and observe for dyspnea or orthopnea. Ask the patient to collect a random stool specimen if able, or ask him or her to describe the stools. The specimen may show steatorrhea. Assess for unintentional weight loss, muscle wasting, jaundice, dark urine, and the symptoms of diabetes mellitus, such as polyuria, polydipsia, and polyphagia. Diagnosis is based on the patient's symptoms and laboratory and imaging assessment. Endoscopic retrograde cholangiopancreatography is done to visualize the pancreatic and common bile ducts. Imaging studies such as CT scanning, contrast-enhanced MRI, abdominal ultrasound, and endoscopic ultrasound are also useful in making the diagnosis. In chronic pancreatitis, laboratory findings include normal or moderately elevated serum amylase and lipocellules. Obstruction of the intrahepatic bile duct can cause elevated. Key features: chronic pancreatitis. 1. Intense abdominal pain, a major symptom that is continuous and burning or gnawing. 2. Abdominal tenderness. 3. Ascites. 4. Possible left upper quadrant mass. 5. Respiratory compromise manifesting with adventitious or diminished breath sounds, dyspnea, or orthopnea. 6. Steatorrhea, clay-colored stools. 7. Weight loss. 8. Jaundice. 9. Dark urine. 10. Polyuria, polydipsia, polyphagia. Serum bilirubin and alkaline phosphatase levels. Intermittent elevations in serum glucose levels are common and can be detected by blood glucose monitoring, both fasting and non-fasting. Interventions. Take action. The focus of caring for the patient with chronic pancreatitis is to manage acute or persistent pain, maintain adequate nutrition, and prevent disease recurrence. Non-surgical management. The primary non-surgical interventions include drug and nutrition therapy. The major intervention for the pain of chronic pancreatitis is drug therapy. Medicate the patient as prescribed according to the assessment of the intensity of pain. Evaluate the effectiveness of the drug intervention. Initially, opioid analgesia is used most frequently, but dependency may occur. Non-opioid analgesics may be tried to relieve pain. Pancreatic enzyme replacement therapy is the standard of care to prevent malnutrition, malabsorption, and excessive weight loss. Pancreatic enzymes are usually prescribed in the form of capsules or tablets that contain varying amounts of amylase, lipase, and protease. Teach patients not to chew or crush pancreatic enzyme replacements that are available as delayed-release capsules or enteric tablets. Teach them to take the enzymes with all meals and snacks. The dosage of pancreatic enzymes depends on the severity of the malabsorption. Record the number and consistency of stools per day to monitor the effectiveness of enzyme therapy. If pancreatic enzyme treatment is effective, the stools should become less frequent and less fatty. Nursing safety priority. Action alert. If the patient has diabetes, insulin or oral anti-diabetic agents for glucose control are prescribed. Patients maintained on total parenteral nutrition are particularly susceptible to elevated glucose levels and require regular insulin additives to the solution. Monitor blood glucose to control hyperglycemia. Check fingerstick blood glucose or sugar levels every 2 to 4 hours. Chapter 55 describes in detail the care associated with TPN. The primary healthcare provider may also prescribe drug therapy to decrease gastric acid. Gastric acid destroys the lipase needed to break down fats. Controlling the acidity of the stomach with 2 blockers or proton pump inhibitors or neutralizing stomach acid with oral sodium bicarbonate may enhance the effectiveness of PERT. Protein and fat malabsorption results in significant weight loss and decreased muscle mass in the patient with chronic pancreatitis. Therefore, the nutritional interventions for acute pancreatitis are also used for chronic pancreatitis. The patient often limits food intake to avoid increased pain. For this reason, nutrition maintenance is often difficult to achieve. Patients receive either total parenteral nutrition or total enteral nutrition, including vitamin and mineral replacement. Collaborate with the registered dietitian nutritionist to teach the patient about long-term dietary management. He or she needs an increased number of calories, up to 400 to 600 calories per day, to maintain weight. Food high in carbohydrates and protein also assists in the healing process. Food high in fat is avoided because it causes or increases diarrhea. Teach all patients to avoid alcohol. Alcohol cessation programs may be recommended. Surgical management. Surgery is not a primary intervention for the treatment of chronic pancreatitis. However, it may be indicated for ongoing abdominal pain, incapacitating relapses of pain, or complications such as a pancreatic abscess or pancreatic pseudocyst. The underlying pathologic changes determine the procedure indicated. Using laparoscopy, the surgeon incises and drains an abscess or pseudocyst. Laparoscopic cholecystectomy or choledochotomy may be indicated if biliary tract disease is an underlying cause of pancreatitis. If the pancreatic duct sphincter is fibrotic, the surgeon performs a sphincterotomy to enlarge it. Endoscopic sphincterotomy may be used for patients who are poor surgical candidates. In some cases, laparoscopic distal pancreatectomy may be appropriate for resection of the distal pancreas or pancreas head. Endoscopic pancreatic necrosectomy and natural orifice transluminal endoscopic surgery are becoming more common for removing necrosed pancreatic tissue. Both procedures are performed through the GI wall without a visible skin incision. The Notes procedure is discussed in surgical management in the inflammation concept exemplar, cholecystitis section. In a few cases, pancreas transplantation may be done. However, this procedure is performed most often for patients with severe, uncontrolled diabetes. Chapter 59 discusses pancreas transplantation, care coordination and transition management. Home care management. Collaborate with the hospital-based case manager or discharge planner about home care or follow-up in another setting. A community-based CM may continue to follow the patient after hospital discharge. If the patient is discharged to home, the living area should be limited to one floor until he or she regains strength and can increase activity. Teach patients and families that toilet facilities must be easily accessible because of chronic steatorrhea and frequent defecation. If they are not easily accessible, a bedside commode is obtained for the home. Self-management education. Because there is no known cure for chronic pancreatitis, patient and family education is aimed at preventing acute episodes of the disease, providing long-term care, and promoting health maintenance. The patient and family education, preparing for self-management, prevention of exacerbations of chronic pancreatitis box outlines self-management to help prevent exacerbations of the disease. Patient and family education, preparing for self-management, prevention of exacerbations of chronic pancreatitis. 1. Avoid things that make your symptoms worse, such as drinking caffeinated beverages. 2. Avoid alcohol ingestion, refer to self-help group for assistance. 3. Avoid nicotine. 4. Eat bland, low-fat, high-protein, and moderate carbohydrate meals. Avoid gastric stimulants such as spices. 5. Eat small meals and snacks high in calories. 6. Take the pancreatic enzymes that have been prescribed for you with meals. 7. Rest frequently. Restrict your activity to one floor until you regain your strength. Patient and family education, preparing for self-management. Prevention of exacerbations of chronic pancreatitis. 1. Avoid things that make your symptoms worse, such as drinking caffeinated beverages. 2. Avoid alcohol ingestion, refer to self-help group for assistance. 3. Avoid nicotine. 4. Eat bland, low-fat, high-protein, and moderate carbohydrate meals. Avoid gastric stimulants such as spices. 5. Eat small meals and snacks high in calories. 6. Take the pancreatic enzymes that have been prescribed for you with meals. 7. Rest frequently. Restrict your activity to one floor until you regain your strength. Patient and family education, preparing for self-management. Enzyme replacement for the patient with chronic pancreatitis. 1. Take pancreatic enzymes with meals and snacks and follow with a glass of water. 2. Administer enzymes after antacid or 2 blockers. 3. Swallow the tablets or capsules without chewing to minimize oral irritation and allow the drug to be released slowly. 4. If you cannot swallow the capsule, pierce the gelatin casing and place contents in applesauce. 5. Do not mix enzyme preparations in protein-containing foods. 6. Wipe your lips after taking enzymes to avoid skin irritation. 7. Do not crush enteric-coated preparations. 8. Follow up on all scheduled laboratory testing. Remind the patient and family members or significant others of the importance of adhering to pancreatic enzyme replacement. The patient must take the prescribed enzymes with meals and snacks to aid in the digestion of food and promote the absorption of fats and proteins. The frequency of defecation poses challenging skin care problems. Instruct the patient to keep the skin dry and free of the abrasive fatty stools, which damage the skin. The skin should be cleaned thoroughly after each stool, and a moisture barrier applied to prevent breakdown and maintain skin integrity. Many products on the market actively repel stool from the skin. Remind the patient to report any skin breakdown so therapeutic interventions to promote skin integrity can be started. Abdominal fistulas are common and present a difficult challenge because pancreatic secretions irritate the skin. If the patient develops diabetes mellitus as a result of chronic pancreatitis, management of elevated glucose levels after discharge from the hospital may require oral anti-diabetic agents or insulin injections. If this is the case, collaborate with the certified diabetes educator to provide in-depth teaching concerning diabetes, its signs and symptoms, medical management, drug therapy, nutrition therapy, blood glucose monitoring, and general care. Chronic illnesses are devastating for families. The high costs of medical insurance, medical treatment, and drug therapy cause serious financial problems. Often the patient with chronic pancreatitis is unable to work. Collaborate with the CM about ways to assist the patient with resources for financial help. Healthcare resources. The patient may require several home visits by nurses, depending on the severity of the chronic health problems and home maintenance and support needs. The nurse assesses the patient for pain, enzyme therapy, and psychosocial adaptation to a chronic illness. Refer him or her and the family to a counselor or a self-help group, such as Alcoholics Anonymous and Al-Anon, if appropriate. Inflammation Concept Exemplar, Acute Pancreatitis. Pathophysiology Review. Acute pancreatitis is a serious and at times life-threatening inflammation of the pancreas. This inflammatory process is caused by a premature activation of excessive pancreatic enzymes that destroy ductal tissue and pancreatic cells, resulting in autodigestion and fibrosis of the pancreas. The pathologic changes occur in different degrees.